Approving the minutes. Can I get a motion?
So moved.
Great.
You're correct.
Are there any corrections?
I do not have any corrections. I looked closely.
Okay. So all in favor?
Aye.
Any opposed? And I will abstain since I was not a part of the board. So with that, and actually before we get started, I wanted to take a few minutes to provide some highlights of Dr. Bassett's tenure on the board. With her departing as of August 31st, I think that she leaves, along with you all, a legacy of continuing to keep the health department in the forefront of public health. So I wanted to just highlight a couple of major actions taken by the board under her tenure as chair, which included Article 81, which was adding sodium warnings. And you'll recall that this was the first action that was taken by the board after the portion size debate. And of course, this sodium warning, we were sued and it was upheld in the courts. And so that was one that I know for a fact that she was very invested in, and you all were very invested in. And again, it continues the board in its forward motion. Another major accomplishment was, and this one sort of speaks to the circular nature of what we do in public health, and that was conforming our menu labeling laws to the feds, which were actually based on our original menu labeling laws. And so this is a great example of sometimes things that start with us, end with us, and that's a good place to be. The other significant accomplishment was the elimination of surgical requirement for gender change in the birth certificate, and that was really a landmark move in the city. And then something that we will be discussing and voting on today is the advancement of X marker and self-certification changes on birth certificates. There was also updating the requirements on daycares in Article 47, including successfully defending our flu vaccine requirements. That was a big one, and I think that we will see those benefits not only in the child population, but in the adult population as well. And then another item that we will be also talking about in today's agenda is the reporting of first episode psychosis, and that really has been a major development. So I think it's important for us to highlight the work that she led as chair and that you all have helped the city move forward in. So take a moment for that. Excellent. So the first thing that we are going to consider is the, excuse me, the issue of first episode psychosis, and we have a presentation that we'll go through. Great, and if you can introduce yourselves, please.
Hi, I'm Dan Anderson. I'm the director of the NYC STAR program.
And I'm Myla Harrison, Assistant Commissioner of the Bureau of Mental Health.
And we're here today to talk about the proposed amendment of Article 11 related to first
Can you
episode.
talk closer to the microphone,
Sure.
please?
Sorry.
Thank you. Yeah.
We're here today to talk about the proposed amendment of Article 11 regarding first episode psychosis. This is a follow-up to our June presentation to the Board of Health, where we proposed modifying the current Article 11, Section 1104 of the Health Code related to first episode psychosis in order to make some improvements to the program and to our reporting requirements around first episode psychosis hospital admission. The proposal that we put forward is to lower the age of required reporting of first episode psychosis hospital admission to age 16 from 18 to age 16, to ensure complete demographic information is included in those reports by adding race and ethnicity to a report of a first episode psychosis hospital admission, and to remove the time limit that the department can hold information of those reported with first episode psychosis. The original amendment contained a 30-day time limit that we proposed to remove. The impact of those changes is because we really do know that it's critical to individual outcomes to connect people with first episode psychosis to services within the first 5 years of illness onset. There's a large body of research and a growing body of research that points to the importance, the value, and the effectiveness of early identification and early intervention for people with first episode psychosis. And this proposed amendment would allow us to address the needs of 16 and 17-year-olds, an important age group who we could not address the needs of when this proposal was originally put forward, because there were no services in New York City specialized for first episode psychosis, 16 and 17-year-olds widely available, and now there are. To assess for racial inequity among first episode psychosis referrals from inpatient psychiatric care. When we put forward the original proposal, we didn't include race or ethnicity information in those reported to us, and as a result, we are really limited in our ability to identify and perhaps intervene to address racial inequities in admissions for first episode psychosis and in reporting to the Department of Health and Mental Hygiene of people hospitalized for first episode psychosis. We want to extend the length of engagement beyond the first 30 days for someone not ready to accept services earlier, or in some cases someone who we haven't been able to successfully locate within the first 30 days of a hospital report. The original proposal had a provision that we had to de-identify reported information 30 days after a report was received, which effectively ended our ability to try to reach someone. But we know that sometimes it takes longer than 30 days to successfully reach and engage somebody in services. When we want to evaluate the effectiveness of services for both those who participate and those who do not participate in the NYC STAR program to determine whether there are additional needs in the community that could be addressed through alternative interventions or additional programmatic changes to how we're providing our services here that could increase and improve on our outcomes. So to review just a little bit of history for anybody who would like that review, in 2013, the Board of Health amended Article 11 of the Health Code to require hospitals to report to the Department of Health and Mental Hygiene when individuals between the ages of 18 or 30 were admitted to the hospital with a first episode of psychotic illness. The proposed amendment was to address inadequate linkages to care for people with first episode psychosis who do not seek or engage successfully in services for a multitude of reasons, but some of the bigger reasons are fragmentation within our healthcare system. We have a large, wonderfully complex behavioral healthcare system in New York City, very rich in resources, very hard to navigate. Barriers to exchange patient information between inpatient and outpatient providers. Providers lacking resources to really ensure engagement and care is successful. People can only see those who walk through their doors, and if somebody doesn't make it through the door, often the case is closed, so something that will allow a continuity of that engagement to continue. And challenges that are on the individual as well as on the systemic level of stigma, denial, fear, lack of support, and confusion related to resources and to the illness itself. In 2014, the Department of Health and Mental Hygiene launched a program to offer services to improve linkages to care. And that's the program I'm the director of here at the Department of Health and Mental Hygiene, the Supportive Transition and Recovery Team. That program provides patient-centered care coordination, psychoeducation, and support services to young adults who have been hospitalized for the first time due to psychosis, and to their involved family members to ensure linkage to care, connect clients to specialized and recovery-oriented services, and support their transition from the hospital back to the community. By 2015, we had expanded across the city and built the capacity to receive reports from and offer services to all New York City residents who are hospitalized in an adult inpatient psychiatric facility. And it's been successful. We've learned a lot along the ways, and it's a constant process of improvement, but we have improved successful linkages to outpatient care. It's been well received by program participants, it's been well received by providers. To date, we've had, well, actually, as of the date I wrote this, we had 1,896 hospital reports received. 1,206 people, or 73% of eligible folks, accepted to start services. So we've been very successful in engaging people. And since the program launch, we've steadily improved on one of our primary indicators, which is the rate of connection to community-based services within the first 30 days following a hospital admission. So overall, if we look at that entire 1,206 people, 80% of program participants successfully attended an outpatient mental health appointment within 30 days of hospital discharge. But that's a number that's growing year by year, quarter by quarter. So in 2018, it was 86%. I believe our first quarter of measuring it, it was 69%. We came to the Board of Health in June to propose modifying the health code, and then a notice of intent was published, and that was done in June 12th of 2018, and we held a public hearing in July 12th of 2018. We received 3 written comments in response to the notice of intent, so I'll summarize those. All of the comments were broadly supportive of the proposed changes. They really were most supportive of the department's effort to reach 16 and 17-year-olds with first episode psychosis and to extend outreach efforts, and we're also supportive of the value of including race and ethnicity information in hospital reports so that the department could have an opportunity to look at racial inequity and racial disparities. Commenters sought clarification about the length of time identifying data would be retained, whether or not guardians would need to consent before minors participate in the NYC STAR program, how data will be used to extend outreach efforts and monitor trends in illness. And at the June Board of Health meeting, some of the board members had raised questions related to parental consent for minors also, the collecting of race and ethnicity information, and the availability for services for people with limited English proficiency. So I'll do my best to answer those. So issue number 1, what will we do with the data? So identifiable information will be used to expand our outreach efforts to those who have been unreachable during the initial 30-day period. That total of the number reported to us is close to 25%, so it's not an insignificant number of people that we want to expand our outreach efforts for. It will be used to comprehensively assess program outcomes and needs of communities during the 5-year time frame of early psychosis. So in the literature for early psychosis, the first 5 years from onset of illness is considered a critical time for intervention. And we want to be able to really look more broadly at that critical time of intervention and see where are the successes and what can we do to capitalize and grow those successes. Information will also be used, now that we're growing a little bit, and we've had this program for a couple of years, to clarify and reduce duplicate reporting if an individual has been previously reported to the department with the information de-identified. Now that we've been doing this for a couple of years, if somebody calls the department and says, I have a person hospitalized in my facility, should they be reported to you? We actually have no way of knowing if they were or not because that person's information has been de-identified. And this will allow us to reduce duplicate reporting and clarify for hospitals who should and who shouldn't actually receive our services. Reported information will, of course, be kept confidential and maintained in a secure database. And I think it's worth, mentioning that the Department of Health and Mental Hygiene manages numerous disease registries and has a very good track record and extensive experience in maintaining the confidentiality of the identified information that we receive. And in line with other registries maintained by the Department of Health and Mental Hygiene, we did not let us set a time limit on the amount of time that we would retain that information. To some degree, maybe trying to move a little closer to treating mental health conditions in the same way that we treat physical health conditions. The amendment language has been updated to broaden the confidentiality provision and further clarify that identifying information will be kept confidential and may not be disclosed without the consent of the person who's the subject of the report or someone authorized to act on their behalf. Issue number 2, do parents need to consent for a minor to participate in NYC START? So, yes, we will typically require parental consent for participation. I can imagine a very rare scenario where there is no involved parent or guardian, or a rare situation where the involvement of the parent or guardian may actually be detrimental to the child and place them at risk. When those situations, should they arise, we will take our lead from the hospital on how to offer services, but we would typically require parental consent, and we expect that that will happen in the context of our outreach and enrollment efforts taking place in family meetings at the hospital with hospital treatment team, family member, and the client all participating in a meeting with us where we outline what our services are, offer the services, answer questions, and hopefully are able to start our engagement process right at that meeting. In line with this and with the board's earlier request, the amendment language has been updated to include parent and guardian name and contact number when the reported individual is a minor, so that we can make sure that we are able to obtain parental parent or guardian consent by being able to contact them. And we clarified circumstances that individuals should be reported to ensure that we reach those over 18 who were first admitted as a minor before these changes were proposed. We realized that by aging down 2 years, we were at risk of losing 2 years of people being reported to us. And we wanted to make sure that if somebody was admitted, that we would be able to offer them services during that early critical phase of first episode psychosis. How will we collect accurate information about race and ethnicity? So the value of adding race and ethnicity information is really important. It'll allow us to assess for racial inequity among referrals within inpatient psychiatric admissions for first episode psychosis and amongst reports to the Department of Health and Mental Hygiene. Having that initial information as reported by the hospital will be a valuable demographic baseline. We don't have that now, so we have no way of saying, you know, for people who are reported and don't accept our services, is there a disparity there that we should be focusing on and trying to understand and improve upon? There are limitations, obviously, with asking for information to be reported. Not everybody assesses race and ethnicity information in the same manner, in the same fashion, and we would perhaps not know whether or not this was the race and ethnicity that somebody would self-identify. And we're aware of that. So to account for this, the program will ask participants to self-identify race and ethnicity, and we will then go and modify those initial reports where necessary to improve the accuracy. But there may well be some people who either refuse to meet with us or who we are never able to successfully engage even in a conversation about self-identifying race and ethnicity information. And for those people, this will at least give us a valuable baseline of information. How will we reach individuals with limited English proficiency? So the START program itself uses interpretation services to provide services to the participant in their preferred language or to the participant's family in their preferred language, as the case may be. Operationally, we inquire at the time of setting up our initial visit with the hospital about the individual's preferred language, and we set in place interpretation services prior to enrollment so that we can make sure that we're able to communicate effectively with the person. Treatment providers across New York State, I believe New York City certainly, who are licensed by the Office of Mental Health, are required to make similar provisions for interpretation services. Inability to provide services in somebody's language isn't a reason for ineligibility in a licensed mental health program. all of the specialized programs for first episode psychosis in New York City have the capacity to provide services in the patient-preferred language, similarly using interpretation services if they don't have a clinical staff member on site who actually is able to communicate directly. There's a value to specialized services, and there's a value to services that are provided in somebody's language. And I think one of the roles that we would play in this sort of critical time of coming out of the hospital and initially engaging in services is to find out where the greater value lies. We have had some folks that we've worked with who preferred going to a specialized provider and using an interpreter to get their services, and we've had some folks that we've worked with who have preferred going to a provider that was able to provide services with a clinician who was able to speak directly to them in their language, even if that wasn't the specialized treatment provider. And so we would take the lead of the person and what's going to best meet their needs, and would make adjustments as we move forward to try to make sure that the services somebody's connecting to is the services that they're most comfortable with and that is best meeting their needs. So, as a conclusion, after reviewing the comments, the department is recommending the proposed changes to the amendment. We believe that the proposed amendment will greatly improve our ability to meet the needs of New Yorkers experiencing first episode psychosis. And I'm happy to do my best to answer any questions.
Great, thank you. Questions? Dr. Foreman.
Thank you again for reviewing all of that. It's a very exciting program. I had just a curiosity question. You showed us some data of the sort of 30-day engagement rate for individuals who were referred to NYC START and how that's increased somewhat. Is there any baseline data prior to the implementation of NYC START? What was the 30-day engagement of first-time psychosis? Is there any research about it?
So, sorry. That is a great question. It's actually a question that many people are very interested in, and that we have a belief that our program might be able to provide some value added to the field around, because what we're doing here is unique. As far as I'm aware, within the entire United States, we're the only Department of Health who has taken a step to operationalize a program and reporting requirements in this way. So the answer is nobody really has a good answer to what the successful engagement rate is. When we developed our initial quality indicator, we modified a quality indicator about what's the rate of engagement in outpatient mental health services for somebody leaving an inpatient psychiatric admission for adults in New York State. And at the time, which was 2014, the rate was very low. It was about 34.7%. But that wasn't necessarily first episode psychosis. That was adults with a behavioral health admission and engaging, or even making it to a first appointment within 30 days following hospital admission. That number actually has improved because this has been a focus in New York State. It's improved a lot higher, I think, for us now.
Can I follow that up?
Yes.
I have one other question. Having the data remain, keeping identifiable data beyond 30 days is very valuable, and I completely support that. One of the uses is that people would call and say, I have someone presenting with the first episode of psychosis who's 19 years old. Should I report it? And that would mean, have they been reported before? When you use your database for that purpose, if you find them, would you also be able to note whether or not they had engaged in care, whether you've been able to find them? Because about 25% of the people you had never reached, this might actually be a second net. I imagine some of those people represent because they never were engaged in care. And will you use that as an opportunity to try again?
Yes, we would. The idea of the program is really to do whatever could be most helpful to successfully bridge that transition. And so we're actually very excited with the idea that we would have an opportunity to reach people who we weren't successfully able to reach before, who didn't successfully connect to services before, and give it a try for that person. Maybe the second time around will be more successful than the first time. We're very hopeful for that.
Thank you.
Dr. Richardson.
Thank you for that presentation. I really appreciate the thoughtful way you addressed the comments and our discussions from the last time, and I fully support the approach that you outlined with respect to really identifying the best linguistically and culturally appropriate setting, treatment setting for each individual. I notice, and I understand, I think, why you're not actually adding information about patients' preferred language to the report that's required from the hospitals. Although I think it'd be helpful if they had that information, but obviously this is something you would identify if you engaged. Are you going to be able to keep that information as part of the registry so that you can track disparities with respect to the population with limited English proficiency? I don't know if you need for it to be included to be able to sort of add that information to the registry, but I want to make sure that you are able to monitor and that you do intend to do that. I think it's very important, not just to have the conversation with the individual, but to actually monitor that over time.
That is a really great question. I can see the value to doing it, and we didn't include it in the original provision because we are trying to be very mindful that hospital reporting, we want there to be as few barriers as possible so that the reports will actually flow in, and each question you ask is one more reason that somebody might not make that report.
I'm a hospital-based physician, I totally understand.
But I do think that that would be an extremely valuable piece of information. So I think that we would look for ways to be able to do that, making sure that we are doing that in a correct fashion. But I would think that we should be able to do that.
Thank you. And actually, to build on that, I think it might be interesting to note of the 25% that don't engage, is language an issue in that? And you just raised that for me.
It's hard to get at that.
Yeah, no, but thank you for that. Yes, Ms. Redletter.
Thank you. Thank you. I add my comments and appreciation for your report and your efforts, which are very sensitive and impressive. I had a few questions following up on, well, I'll just follow up on the language and ethnicity issue. Just wondering if you'll be able to, or you make an effort to retroactively add that information to the individuals that are already in your registry. I know it's going to be new, but if you, that may be related to how you engage and whether you're engaged with them now. And that leads to my second question, because the original sort of structure of your program was you're interested in engaging the individuals in care, and the registry was only available to you for 30 days. So it seems like the focus was that, you know, connection to a provider. But now with your interest in extending the registry information, you know, a much longer time, can you just explain kind of the format of your program and what you view as success and how long your employees follow the patient, or what kind of information they might gather over time?
Absolutely. So to answer your first question about being able to retrospectively go back and add language information, we could do that for people who accepted our services. We wouldn't have any way to do it for people who didn't accept our services because those have been de-identified, so we can't.
Of course, but I mean, you know, if there is a set of patients that you currently engage with, that would just give you a little more information with those who have been successfully engaged.
Yeah, for people who do successfully engage with our program, we do then actually have language information because it's important for the workers to be able to know what language and what interpretation needs they're going to have in working with somebody. So we actually would have that for anybody who accepted services, but wouldn't be able to do anything about the people who didn't. In terms of the flow of the program and what it looks like over time, so we use this critical time intervention model, which is an intentional, time-limited model of decreasing frequency and intensity over time. So the point is not to become the vital service that somebody depends on, but to be the bridge to the vital service that will endure after we close the case. To that end, we work for, our model is a 3-month model from when somebody comes out of the hospital. We don't, count hospital time as part of our 3 months, but our intention is to have a 3-month model, 3 months for when somebody comes out of the hospital. We have a procedure in place to be able to extend that time frame for when at 3 months the engagement hasn't happened, there's additional needs that haven't been met. So most of our cases do close roughly at the 3-month time frame, but it's not set in stone, and we will extend for as long as necessary to make sure that we've addressed the underlying need that somebody has and done our very best to really make that connection successful. We also do a follow-up piece. So part of our program model has us finding out how things have gone 3 months after we close their case, which would be 6 months after we received it, and then 6 months after that, so 1 year after we received it. We contact people and basically check in with them to see how successful that connection has been for them, has anything changed, and where somebody has a new need that arises, or if we contact somebody and find that there's a crisis, we do take steps to then put in supports and services and interventions.
Thank you. That's helpful to understand your process, and then the need to have the information available for a longer period of time. So I'm just wondering if you could just explain a little bit more. I know my colleague and at the last meeting, Ms. Neowith, and some of the commenters are questioning the sort of need to have this registry available, information identified, long term. And if the sort of model or the framework for effective care is 5 years, is that something that you've thought about, limiting or having it available for a 5-year period to evaluate services, or, just wondering how you would use the data post the 12-month period that you're currently assessing?
Well, one of the first pieces that having that information will help us with is as we go down the years, and 16 to 30 is a fairly large age range. When people are admitted to a hospital, the hospital may not know whether or not a previous admission, if a previous admission is known to them, was a qualifying admission for first episode psychosis services. People are admitted for different reasons sometimes, with similar behavior. Different diagnoses are given at the time. Some would be eligible for us, some would not be. So it will really allow us to be able to tell a hospital whether or not we can provide services to this individual. If we de-identify even after 5 years, we wouldn't have the ability to do that for the full 16 to 30 age range. Another piece of what we really want to do is this whole effort around specialized services and early intervention for first episode psychosis is, to say it's new is perhaps incorrect, but it's relatively recent, especially in the United States, to be doing something comprehensive and viewing this through more of a public health lens is a relatively recent development here. We really do want to be able to look at effectiveness and look at trends over time and be able to say, is this successful? What could we do to make this more successful? Is there a need that we haven't been able to identify that looking at information over time would allow us to find? With the tools that we have at our disposal to be able to do that, and with this being a very small sort of incidence, condition, our most effective way of being able to do that is to be able to actually look at the individuals who receive services, the individuals who were eligible and didn't receive services over time, and maybe compare outcomes and engagement in community resources and how well somebody has done in the community, and potentially be able to reach out to that person if we find that the need is we should be reaching out further into the future. Maybe we should be doing something more in that 5-year period of time. Maybe 5 years isn't the right number. Maybe it needs to be a different number. To be able to use that information to make those decisions, I think adds enormous value.
That makes a lot of sense. Thank you.
Dr. Klitzman.
Thank you. I join my colleagues in noting with really awe the tremendous progress that you've made in what is, for the department, a relatively new effort. And I would imagine that given the success in the percentage of patients that you reach, the remaining group becomes more challenging to find. So I'm wondering if you can tell us now, or perhaps report back in the future, what have you learned about what else needs to be done to reach this hard-to-reach population as you think about expanding your outreach efforts?
We have learned a few things, even in that first 30-day time frame. One of the things that we learned is we need more than 30 days. So the expansion of outreach is, I think, going to help inform us a lot more of where some of those barriers are. We unfortunately have had cases where in the first 30 days we haven't even been able to successfully meet a person, and we're closing their case for a variety of reasons. Certainly we've learned that we are most successful if we are able to intervene at the time of hospital admission. Our success rate is much higher when we are known to the individual as part of the plan coming out of the hospital than it is if we're trying to find somebody in the community who's already left the hospital. So we've placed a great emphasis on making sure that reports come into us in a time frame where we can actually meet the person in the hospital. We have had reports come to us, and we do our absolute best with those reports for people who were hospitalized but now have been discharged in the community, and we've tried to reach out to them in the community, and we have some success, but not the same rate of success in any way, shape, or form. So that's the one biggest thing, is the earlier we can get there, the more successful we can be. We're kind of hoping with having this information for longer that it will give us a really great opportunity to do further outreach and engagement with people who we haven't been able to successfully engage, and that we will learn a lot from those efforts about what we need to change in terms of how we're doing what we're doing and what works most effectively. One of the real limitations of that 30-day time frame is we don't know what happens to some of these people who we never successfully are able to connect with at all.
And just a follow-up question, I know in the past with reporting of certain infectious diseases, there was not just a passive reporting program, but an active reporting program as well, where the department would go to emergency rooms to look through new admits. Can you explain to us a little bit about the reporting process? Is it an active process, passive process, both? How are you thinking about reporting?
So the reporting process is based on the clinical determination of the treating provider at the hospital. So we've defined the diagnoses and the age range and the admission, that this is, an initial admission for a first episode of one of these diagnoses. But the actual determination of whether or not somebody is a first episode of psychosis isn't a diagnostic label in and of itself. It's an assessment of whether or not this presentation is the onset of a psychotic condition or not the onset of a psychotic condition. So we don't do, if I'm understanding it, I may be getting it wrong, the passive reporting, we don't have like an automated system that would, automatically report certain diagnoses of people of certain age range who have been admitted to the hospital. It does take the clinician at the hospital making a determination that this person then meets reporting criteria. But and with this new effort, of course, we will be doing a new round. We do extensive outreach to hospitals. We do presentations to all of the hospitals within patient psychiatry. We do our very best to actually get not just to the leadership of that hospital, but to the team on the floor of each unit, so that we have an opportunity to really talk with everybody who would be providing services to somebody eligible for reporting, to really frame, here's what we're looking for. If you see this presentation, here's who we wish that you would report to us. If you have a question about whether or not this person should be reported to us, please give us a call and say, I've got a person here, I'm not sure, what do you think? So that we can help guide that decision process. And to that end, it's an active process of outreach and engagement with the hospitals around the reporting requirements. But no, we haven't gone to hospitals to review records to look for people who could have been reported to us. At that point, they would have already been discharged anyways.
Thank you.
Another question?
This conversation just gets more and more interesting. So based actually on your question, your response, I fully understand that it's the attachment of the diagnosis, and that is typically done at the end of the hospitalization and actually may not exist within the hospital database until the patient is discharged and it's gone to the coders and billers. But it does seem that given the fact that virtually every hospital in New York City now has switched over to an electronic health record, that it might be possible to do a check of the completeness of the reporting by some kind of electronic data stream, diagnosis-based, that could be culled from perhaps the Health Information Exchange, from HealthX. And so you would get a sense of how well the hospitals are doing with the reporting, because there's an independent electronic source of whether or not there was a first hospitalization for any one of a given diagnosis of individuals with a certain age. And I think this would be a very good use of the Health Information Exchange database. So I encourage you to perhaps look into that.
Thank you. That's actually a great suggestion. And I do think incrementally, as systems improve and the ability to have that sort of electronic health exchange improves, that we will have opportunities to get better and better at this and to take advantage of it. I do know that one of the recent changes for the managed care organizations, at least for the Medicaid managed care organizations, is guidance that they need to start being able to identify those who are first episode psychosis. And as efforts like that sort of merge together, I think there's a greater and greater opportunity for us to get the information better and more seamlessly and more easily reportable to us.
Great, thank you. And one more question. Yes.
One more quick question, which was just generated by your answer. Speaking about managed care, I'm just really wondering if insurance coverage is at all a barrier to care, and is that something you look at?
I think the answer to that is that insurance coverage is really, really valuable and very variable. About 60% of the people we work with have Medicaid. And certainly with Medicaid, there isn't an insurance barrier to receiving these services. The specialized first episode psychosis service programs that we really try to connect people with as our first opportunity for the best treatment possible are sort of equipped. They're under the state, and the state has made provisions so that they will be able to provide services independent of ability to pay, independent of insurance. So that's a wonderful thing. Not everybody is actually eligible for those programs. Not everybody connects to those programs. So insurance does play a major role in what somebody is eligible to receive. One of the challenges that we also have is it's one thing to be able to get services. It's another thing to be able to fill prescriptions. And so you really do have to have the means to be able to fill a prescription if you're prescribed what can be at times a very expensive antipsychotic medication regimen.
So it's possible that some of the patients that you connect with and refer may not have insurance coverage to pay for medication, for example. They could get services through the state programs, but medication might not be covered.
When that's the case, that's one of the pieces of work that our team is heavily involved in. Is figuring out how can we have this plan actually meet the person's needs. So there are venues that we can go through in order to get people prescription coverage, either through a health and hospitals facility, for instance. Some of these specialized programs are embedded within health and hospitals. Some of them are not. The ones that are embedded in health and hospitals facilities, if the treating psychiatrist isn't health and hospital psychiatrist, they can avail themselves of the prescription benefit programs available through health and hospitals and get their medications that way. So some of the programs we work with are also operated under state provisions, where there are provisions for being able to provide people coverage where they lack the coverage. And part of what we do is try to connect those dots, because those resources are precious and few.
Great. Any other questions? Okay, I'll entertain a motion.
Move to approve.
Second. Hearing no more discussion or questions, we'll call for the votes. All in favor?
Aye.
Opposed? None. Abstained? None. Great. Thank you very much.
Thank you very much.
Okay, so now we will transition to our next presentation for board consideration and talking about further amendments to the gender marker provisions.
Good morning. Hi, my name is Gretchen Van Wy. I'm the Assistant Commissioner and now Registrar of the for the Bureau of Vital Statistics. You'll notice that I'm not Steve Schwartz. He is he's doing well. He's getting settled into his new role at NCHS, and so I'm here today to speak with you about something that he presented to you in June. So it's the proposed changes to the transgender birth certificates with two components. We're calling self-attestation and X. So I'm presenting that to you today for your consideration for adoption. So in summary, a notice of intention to amend Article 20705 of the Health Code was presented by Steve and published into the city record in June. The way it will work is that a person 18 years and older will self-attest with a notarized statement requesting a change in their birth certificate to female, male, or X to conform to their gender identity. And a person less than 18 years old would have their parent or legal guardian provide that notarized consent for them. So X. X signifies a sex that is not exclusively male nor female. It's a category one might call binary, non-binary, and it's only for sex change requests, and it's something that we're doing so just for corrections. It's not a selection to be chosen at the time of birth. We held a hearing for this proposal in July. No one actually attended the hearing and testified, but we did receive 2 written comments. One comment was from the Office of the Chief Medical Examiner. They were interested in death certificates and consistency with death certificates, which we welcome. The death certificate is a separate document requiring a separate process, so we're planning to work with them on the death certificates going forward. But we don't have a change regarding those to this proposal. We also received comments from the Sylvia Rivera Law Project, and they had suggested the elimination of sex designations on birth certificates. So that is something that has been in the ether in discussion in the past. It is something that we had not proposed for this amendment because it is a consideration of some organizations and some advocates that having a sex designation on a birth certificate is a human right. That may change, the position on this may change over time, but currently the proposal remains as it is with a sex designation on the birth certificate, on the legal portion of it. And there was a comment about an interim liaison position coordinating this activity with other city agencies. And we are working closely with our sister agencies on this and other projects related to gender nonconforming population and serving that population. So after the consideration of all the comments received, we've made no changes to the proposed amendment, and it stands as it is. And we're also working on an implementation and a communication plan around it. So for this, we are updating our protocols internally. We're working on communication changes to our website and developing guidance for applicants. Working on a similar type of rollout as we did last time in 2015 when we rolled out the gender marker change implementation. So I bring this to you for your potential adoption, and I wanted to answer any questions that you might have.
Any questions? That's Klitzman.
Thank you, and first of all, congratulations on your new role as registrar.
Thank you.
I look forward to working with you.
Thank you.
My question relates to the comments raised by the OCME, and I know you said you're going to be working with them. Do you have a sense yet of how that would work? I can envision a situation where the OCME would make a determination based on, the evidence presented to them, which may or may not conform to the birth certificate.
Right. So thank you very much. And the concern is, of course, that currently the practice is to make a designation based on anatomy. And this would be something that we would need to develop a protocol for New York City-born decedents who are with the OCME. So they would be interested in having a copy of a New York City birth certificate. There will be a number of challenges that we'll work through with them. People, of course, can die in New York City, but be born anywhere. There would need to be a mechanism in place. So there are a lot of operational concerns that we want to address, and there's some other things that we're, while we're looking at the death certificate, we want to see if there are other fields or other areas that we might want to address. So it would be part of a larger effort to get us the best quality data there. But it's really an operational concern in trying to figure out the protocol for people both born in New York City and then what to do about others.
Ms. Rutland, I'm going this way now.
Thank you. I find this topic really interesting and, forward-thinking and challenging at the same time relative to the individuals who might be interested in changing their designation. And that's why you mentioned it briefly there. That's why I think guidance for applicants is a really important part of this process. I think, letting, as individuals come to make a change in their sex on their birth certificate, that they are aware of some of these challenges that will potentially be worked out in the future. But, the issue of the death certificate is something, if they were proactively thinking about it and their family was aware of that, and that would be something that could be communicated proactively. And also the challenges with passports or driver's license or other things that may be inconsistent, and what the implications for that is. I just think an educated consumer at this point is really important, since the agencies are not yet in alignment with, how to handle this consistently.
Great, thank you. That's important feedback.
Dr. Foreman.
I had a question about how the medical examiner currently handles cases where an individual who presents for a medical examination after death has undergone previously gender reassignment surgery. Let's say male to female. How do they designate the certificates now? If they do it based on anatomy, and I just don't know enough about this, what do they do? Because there could already be cases where there is an inconsistency.
So that's a great question. Honestly, I'm not really in the best position to answer the question of what their internal protocols are. They've made reference to using anatomy, but of course, as you present, there are a lot of different variations and stages that people could be in transitioning. So that would have to be taken into account, in addition to, the role of the informant on the death certificate. Who was that person who is providing a lot of the information about the individual? So there's a lot to figure out there.
I raise it just because I think this presents an opportunity to improve the way gender assignment is made on a death certificate, and that the system we currently have in place is probably not perfect and has problems already. So we're not going for something that's perfect and adding new problems. We probably have problems we don't know about.
That's right. I agree.
Uncover.
Absolutely.
And hopefully come out better.
Yes, absolutely.
Any other questions?
Just wanted to let the board members know that the city council simultaneously is also moving in this direction, so you may be hearing about that later today too. So there's be changes to the administrative code and health code.
Very important addition, thank you. All right, hearing no further discussion, I'll entertain a motion. So moved. Second?
Second.
All in favor?
Aye.
Any opposed? And no abstentions. All right, it passes. All right, thank you all very much, and we are adjourning our meeting. Thank you.